Hello friends, welcome back to our YouTube channel Doctorscorner. In this today's particular video, we are going to discuss a very important clinical condition known as gout. So we are going to discuss this condition under this following objectives or side headings. First is we'll deal what is the definition about this and briefly about the epidemiology of the gout. Then we'll discuss about the pathogenesis, how exactly this disease condition manifests, or what is the pathophysiology of this, that is the pathogenesis. Then we'll discuss about the preclinical presentation or clinical manifestations of this disease, or that is the signs and symptoms. Then we'll discuss about the laboratory diagnosis or confirmation of the particular disease by laboratory test, that is the laboratory diagnosis. And finally we'll discuss the management or the treatment aspect of this clinical condition. So this topic, as far as the MBBS syllabus is concerned, this will be taught in the subject biochemistry in the first year of MBBS, in the applied aspect of purine metabolism. Then in the pathology 2 this will be taught, and also in the general medicine, and also in orthopedics and super specialty rheumatology topic is this gout. Okay, so before starting, I would like to give a medical disclaimer that whatever we are going to discuss here is mainly for the educational purpose, and mainly our intention is to cover this topic for the benefit of the undergraduate and postgraduate students of medical specialities, so that we can discuss and they should have an updated knowledge. Okay, it is nowhere, or this thing is not discussed with an intention to have a treatment for a general public. If any general public or non-medical public is watching this particular video just for the sake of knowledge, it's okay, but please don't take self-medication based on the knowledge you gather by this particular video. Okay, so I have clearly given the medical disclaimer, it is only for the educational purpose. Okay, now come to the topic gout. So what is the definition or epidemiology? What does this particular disease means, and what are these manifestation and all? First definition. So see, it's a metabolic condition in which there we see hyperuricemia. So it is a metabolic condition in which hyperuricemia is seen. So it is a metabolic disorder which is characterized by monoarticular, or typically it manifests as monoarticular inflammatory arthropathy. And which leads to the deposition of monosodium urate crystals in the joints. So what is the definition of this clinical condition? It is a hyperuricemic metabolic disorder which will typically manifest as monoarticular inflammatory arthropathy. Monoarticular means single joint inflammatory arthropathy, or the joint disorder. Basically it's an inflammatory disorder, and it leads to the deposition of monosodium urate crystals because of the high content of uric acid. So what is this definition, or actually gout means? So let me elaborate. So hyperuricemia means increase in the uric acid level in the blood. Okay, so if there is increase in the uric acid level in the blood more than the normal, we discuss what is normal and all under the pathogenesis of this particular condition. So first, coming to the definition. So basically what happens is the uric acid level which is normal in the blood is increased, that is normal uric acid level is increased, and it leads to the deposition of the monosodium urate crystals in the joints, particularly one single joint, and that joint is the first metatarsophalangeal joint of, that is the big toe. Okay, the big toe of the foot. So metatarsophalangeal joint of the big toe is usually affected. So, and there is a deposition of the monosodium urate crystals due to the elevated level of the uric acids, which will causes the inflammation of this joint, and it leads to a clinical condition known as gout. That is the definition of the gout. Okay, hope that is clear. Now we'll just discuss briefly about the epidemiology of this particular condition. Okay, so this one is the most commonly involved joint, that is the first metatarsophalangeal joint. We'll discuss in detail in the clinical features too. First we'll have a rough idea about some few points about the epidemiology. Okay, so greater than 90% of the people whom it is affected. Okay, so the 90% of the people who are affected are 90% of the people who are affected by this clinical condition of the gout are more than 30 or 40 years old. That is, the risk factor is higher age group, so it is not seen under the 30 years of age. Generally, majority of the people who are suffering from this clinical condition are above 30 years of age. Then it is more common in males as compared to the females. So average is 3:1, or you can say within a range of 2 to 6:1. So males are more commonly affected by this clinical condition. So male female ratio is 2 to 6:1, or average 3:1. Then females or the woman, generally they are affected, they are not affected, they are post-menopausal women are affected, if at all they are affected. So it will be a higher age group. Okay, that is after the menopause this clinical condition can be seen, but mainly it is seen in the males more commonly as compared to the females, and around 1 to 4% of the general population is affected by this clinical condition worldwide. So that means around 50 million people, more than 50 million people worldwide are affected by this clinical condition. Are affected by this clinical condition gout. So these are the few words about the epidemiology. So we have covered the first objective or the first side heading under this topic, that is definition and epidemiology. Now come to the pathogenesis. Pathogenesis, that is how this disease will develop. Okay, what are the pathophysiological conditions and all. Okay, so as I said in the definition itself, it is a hyperuremic condition. That is, it is mainly due to increase in the uric acid level in the blood. So you should know what is the normal uric acid level then. So you know, in males the uric acid level ranges from 3.4 to 7 milligram per deciliter, and females around 2.5 to 5.7 milligram per deciliter. If we take just a round figure, it is around 3 to 7 milligram per deciliter, that is in the blood. In males, that is the normal range, and in females it is around 2 to 5 milligram per deciliter. So if it crosses more than 7 milligram per deciliter roughly, then that condition it is hyperuricemia, which may precipitate the gouty attacks or gout. Remember, not all hyperuricemia will lead to the gout. Okay, but in the gout the main cause is, or the main pathogenesis is, increase in the uric acid level. So increase that is greater than 6.8 milligram per deciliter is the more specific term for hyperuricemia, but you can take it at round figure as 7, or 7 for males, and females it is 6 milligram per deciliter. So if the uric acid level in general crosses greater than 7 milligram per deciliter, then it leads to the hyperuricemia. Now why it will increase, what are the causes, okay, or what are the risk factors for that? So before that we should understand how this uric acid is formed. So it is found mainly by the purine metabolism. So you should know what is purines. So purines are generally nitrogen bases. We won't go in detail, that is the biochemical structure and all right now. If time permits, we'll discuss in some other biochemistry lecture of purine metabolism. So purines are a nitrogenous base, purines and pyrimidines. So examples of purines are adenine and guanine. Okay, You can see the structures. We are not going to go in detail about this. So generally, these purines are important constituents of the nucleic acids like DNA and RNA, which is important for transferring the genetic material, okay, inside the cells. So DNA and RNA, the constituents of this DNA RNA is mainly this one, nitrogenous bases. Then it has a pentose sugar, either ribose sugar or deoxyribose sugar, and a phosphate group. So these three constituents, pentose sugar, phosphate group, and the this one, nitrogenous base. Okay, nitrogenous base can be purine and pyrimidine. So one of the nitrogenous base is purine, this adenine and guanine. So this constitute one of the constituents of this nucleic acids are DNA and RNA. So after the cell metabolism, so this DNA and RNA will break down and it leads to the metabolism of this particular purines. So ultimately the end products of this purine metabolism is the uric acid. So from where the uric acid is formed? From the purine metabolism. Okay, so the major source for uric acid is purines. Okay, so usually these purines are formed, 80% of the purines are formed by the metabolism in our cells itself, but 20% of the purines are derived by the diet. Okay, so we'll discuss what are the food rich in purines. Okay, so purine rich food is red meat, seafood, alcohol, then organ meat, then the sweetened beverages like soft drinks, sodas and all, which contains the high fructose content. Okay, sweetened packaged food, okay, containing the fructose also has the purines. So this food in the diet is having the high content of the purines. If you take this food in a more quantity or in increased quantity, then more likely the uric acid level will get increased in our body. Earlier it used to be called as the king's disease, because generally kings would have been means they will afford these things, and generally they has a gouty flare. So we'll discuss about what is gouty flares or the acute gout. Right now in the pathogenesis, the major cause of this is increase in the uric acid. But remember, not all uric acid level, not all people having the increased uric acid level will suffer from the gout. But in the gout, the major thing is there is increase in the gout uric acid level, but many a times the uric acid level will be remaining normal. Why, we will discuss in the subsequent sections. Right now remember, in the pathogenesis mainly there is increase in the uric acid. Now increase in the uric acid level more than the normal, then they cause precipitation into crystals and they form monosodium crystals, monosodium urate crystals. Okay, can be abbreviated as MSU crystals. So these crystals get deposited in the joints, and most commonly they will get deposited 70 to 90% of the times they will deposit at the great toe, that is at the first metatarsophalangeal joint. So these crystals get deposited here, uric acid crystal, that is monosodium urate crystals, because of the excess production of the uric acid. So it's like to explain it more clearly by giving some example, salt and water. Okay, suppose in a container there is a water, and on this we pour the salt. Okay, so it will get dissolved. Again we put salt, so it will get dissolved. So further, if we increase the quantity of the salt, then a level will come when it gets saturated, it will not further get dissolved, it will precipitate into crystals. So similar thing happens here in the body. So whenever there is excess of the uric acid level, it gets precipitated into formation of the crystal, that is monosodium urate crystals, and that crystals get deposited in the joint, especially the first metatarsophalangeal joints of the foot, and it will leads to the inflammation of the joint, and that's why it is a monoarticular, need not necessarily monoarticular, but many a times mono means single joint, inflammatory arthropathy or arthritis. Okay, so inflammatory joint disorder. So gout is basically a joint disorder, a single joint, because of the increased level of uric acid level. So this is the pathogenesis, why this will occur. So there are so many risk factors in that. We will discuss about the risk factors in the pathogenesis itself, in whom this gout will occur. Who are the people who are at high risk? So first and the foremost thing we have discussed in the epidemiology, males are at high risk. Okay, the male female ratio is more. Okay, so males are more commonly affected. Then the older age group. Okay, so generally it is more than 30 or 40 years of age people are suffering from this particular condition. So as the age advances, the more likely the person will get this disease gout. Okay, so younger people are not affected generally by this particular disorder. Then dietary factors. So dietary factors we have already discussed. The purine rich food. So this purine rich foods will causes this one will lead to gouty arthritis because of the hyperuricemia. Okay, and certain medical conditions like diabetes, hypertension, obesity. Medical conditions like diabetes, obesity, so they are at high risk for developing this particular disease by forming the acidic environment in our body, that is acidosis. Diabetic mellitus, chronic hypertension, then hyperlipidemia, then also chronic renal diseases. Okay, chronic renal diseases, that is because of the chronic renal diseases there is less excretion of this uric acid. So the major cause for this is either increased production of the uric acid or decreased excretion. Increased production can be either due to genetic factors or because of this one dietary factors, or this medical conditions may stimulate the production of the more accumulation of the uric acid because of the acidic environment. And finally it is also due to the increased or decreased excretion of the products. Okay, so decreased excretion of the uric acid may be due to the renal failure and all. Okay, then finally few drugs which are used therapeutically can cause the increase in the uric acid level, like diuretics, commonly used for hypertension, treating the hypertension and all. Okay, thiazide diuretics can cause hyperuricemia. Then NSAIDs like aspirin also causes that. Then chemotherapeutic drugs like cyclosporine and all. Okay, so they also cause, apart from that, anti-tubercular drugs like ethambutol, pyrazinamide. Okay, so these drugs can also causes the increase in the level of uric acid. So these are the risk factors for the development of this particular condition, gout. So we have discussed about the definition, then about the pathogenesis, how this generally this will occur. Then we'll discuss about the clinical manifestation of this condition, gout, or what are the clinical features. So clinical features basically involve signs and symptoms. So generally the patient will present with an acute gout or a gouty flare. So what do you mean by this acute gouty flare is, so as we have discussed in the pathogenesis, that there is a deposition of the monosodium urate crystals in the first metatarsophalangeal joint, that is the most commonly. Okay, generally these are deposited in an organized matrix, but there are certain triggering factors. Okay, so there are certain triggering factors like excess of that particular diets which I have already discussed, that is alcohol or red meat and all, that will trigger this monosodium urate crystals to get released from this organized matrix into the synovial fluid and irritate the synovial cells, and ultimately it will lead to the mononuclear cells or the macrophages to accumulate and causes the inflammation. Okay, so that acute gouty flare means acute inflammation of these joints. Particularly 90% of the patients will present at the first toe, that is the metatarsophalangeal joint. Okay, so because of that gouty flare, the triggering factors is, one is the diet, then another one is certain infections, or also due to these certain type of stress like surgeries and all, or certain trauma can inflare, or dehydration, less amount of the food, okay, left amount of the water in the body, that will causes the precipitation of the crystal. So all these triggering factors will lead to the acute gouty flare, that is acute. The patient will present with the joint pain, acute joint pain. Okay, most commonly first metatarsophalangeal joint, need not necessarily this thing, but 90% of the patient will present with this, or else the other joints like ankle joint, pain and tenderness. You can see the inflammatory features like pain, tenderness, redness, swelling, and increase in the temperature. Okay, then knee joint can be affected, or else then even the wrist, finger joint and the elbow joint can be affected in few of the cases. Okay, so first thing is joint pain. So generally this joint pain does not last for around more than 10 days. So within 7 to 10 days it will subside. That is the acute gouty flare. Okay, so non-medical treatment like rest and ice packs will help, and some NSAIDs or the painkillers will effectively relieve this thing. But clinically the patient will present as one of the greatest pain they have ever experienced in their life for the first time. So many a times it will awaken the patient from the deep sleep, or in the late night or in the early morning. So they will feel such an inflamed condition in the great toe, that is that they will explain it as one of the worst pain they have ever experienced in their life. Okay, so that is one of the clinical manifestations. First is the joint pain, and it is relieved by generally the common NSAIDs and all we'll discuss about in the treatment clinical features. Then if the condition, that is this chronic, if this condition of hyperuricemia continues, then it will lead to the chronic gout, that is the hyperuricemia for years. Then it may lead to the deposition of the monosodium urate crystals in the subcutaneous tissues, which are sometimes termed as tophi. Okay, so we can see that tophi in the ears, the deposition of these crystals in the subcutaneous region or connective tissues. Also in the joints itself we can see, okay, tophaceous deposit in the fingers. Then sometimes this can lead to the deposition of kidney stones, or known as renal stones. Renal stones, that is the uric acid stones. Excess of the uric acid will lead to the deposition of the monosodium urate crystals, which will form these stones in the kidneys and the ureters, and will present as a renal colic, that is pain in the abdomen and all. So these are the clinical manifestation of the chronic gout. Apart from that, there are signs of inflammation, and this inflammation will causes the skin pruritus and the desquamation of the skin over the affected joints, and it may leads to even the arthropathy, that is arthritis, that is damage or the deformity of the joints in the chronic conditions. Okay, so these are the clinical manifestations. Apart from that, due to the inflammation, fever can be present. A patient will present present with a fever. Also there will be a general malaise because of the inflammatory condition. So these are the clinical manifestations of this particular condition. So we have discussed the definition, pathogenesis and clinical manifestation. Now how to confirm this particular condition is a gout from, and how to differentiate from the other similar arthritis like psoriatic arthritis or septic arthritis and all, that is the laboratory diagnosis. So the gold standard for the laboratory diagnosis here is needle aspiration of the synovial fluid from the inflamed joint and microscopic examination, that is the this one, needle aspiration. From this the synovial fluid is removed and observed under the microscope, that is the laboratory diagnosis. So for the laboratory diagnosis, what is the gold standard or the diagnostic gold standard feature is confirmation of the monosodium urate crystals in the synovial fluid. So generally the synovial fluid, if examination, it will appear as cloudy, okay, due to the inflammatory cells, which will be around 50,000 cells per cubic micro, up to 75,000 cells, but it will not be more. So to differentiate it from the septic arthritis, if it is more in amount of the inflammatory cells, it will lead to it is the diagnosis of the septic arthritis. And it is aseptic, that is there will be no bacteria, but the diagnostic feature is this one, monosodium urate crystals, that is around needle shaped. They are needle shaped, and under the polarized light they will be negatively birefringent. So in pseudo gout, Under the polarized light they will be positively birefringent, but here in the proper gout it is negatively divergent. This is the gold standard needle shaped crystals what you see, that is a monosodium crystal deposition in the synovial fluid. If you see, then it is almost the diagnosis is confirmed. Okay, apart from this, the x-ray or the radiographic many of the times in acute gout this radiographic features will be normal, but typically these punched out erosions are seen. Then it is also known as mouth bitten appearance, that is sclerotic overhanging edges can be seen, or sometimes it can be normal also and confirmed by the CT scan. So apart from this synovial fluid examination, radiography, other blood tests like inflammatory markers like C-reactive proteins and ESR are generally elevated. Okay, and most importantly uric acid level is elevated, but many times during the acute attacks uric acid level may not be elevated or in fact normal, because the inflammatory mediators like interleukins, okay, interleukins will have one of the interleukins like interleukin 2 or 6, they will causes uricosuric effect. Interleukins uricosuric effect, that is they will causes the excretion of the uric acid up to 2 mg per deciliter will be reduced. So sometimes even at the time of the acute gout the uric acid level may appear to be normal, within the normal range. Okay, but clinically we have to confirm it, and laboratory, if there is a monosodium urate crystals in the synovial fluid, it is almost confirmatory of the gout. So this is the laboratory diagnosis. Then finally about the treatment of the gout. Treatment. So for the acute gouty flares, the gold standard treatment is the NSAIDs, that is the painkillers like ibuprofen, indomethacin. I'll discuss about these drugs in detail in next videos. Time being, just I'm mentioning the names of the particular drugs. NSAIDs can be given, which will effectively release the signs and symptoms of the inflammation, and it will be subsided within 7 to 10 days. In majority of the patients will be relieved by this NSAIDs. Along with this, there is one more drug which is known as colchicine. Remember, aspirin is a NSAIDs, but we should avoid this aspirin because aspirin itself will causes hyperuricemia. Okay, this colchicine should be given within 48 hours. It is also an anti-inflammatory drug. Exact mechanism we'll discuss in the next video, how colchicine will be helpful in reducing the inflammation in the gouty arthritis or the gouty flare. Then finally we will, if not control, we can give glucocorticoids. Okay, glucocorticoids or the steroids, can be given either orally or systemically. This can be given to relieve the acute gouty flare. So generally it will subside. Then there are other drugs which are known as urate lowering therapy. Okay, urate lowering therapy. So this is not given to all the patients. If the patients are getting relieved by the NSAIDs and the colchicine and all, there is no need to give this further extra drugs. So there are this to be given in only the patients in whom there is a chronic gout, that is gout is not relieved even after the lifestyle changes and all, and there is hyperuricemia for a longer time, and it is causing the deformity of the joints and all, or if the gouty flares is more than 1 or 2 times, okay, or it is causing the renal stones, that is uric acid stone, then we should give this urate lowering therapy. And this urate lowering therapy itself can flare a acute gouty attack. How means, whenever we are giving certain drugs of urate lowering therapy, this monosodium urates, due to the action of these drugs, they will again tend to precipitate from the organized matrix which are there in the synovial fluid. They are situated, they will again tend to come into the joint tissue and causes the inflammation, and further it is presumed that it will lead to the acute gouty flare. Okay, so urate lowering therapy, the drugs are allopurinol and febuxostat. Okay, allopurinol, which will inhibit the xanthine oxidase enzyme. This is one of the key enzyme in this metabolism of the purine. that is how purines is converted into uric acid. So if we block this allopurinol, so this pathway is inhibited and there is less production of the uric acid, okay, allopurinol and this newer drug febuxostat, okay. Along with that, uricosuric drugs, that is increased excretion of the uric acid by giving probenecid and then sulfenparazone. There is one more newer drug, rasburicase, that is it will stimulate this enzyme urate oxidase, okay. So we'll discuss in detail about this in some other drugs. These are urate lowering therapy, that is decreasing the uric acid level. Remember, not all patients to be given this, only few selected patients, which I have already said, that is uric acid, the renal stone patients or continuous more episodes are seen within a year, okay. Generally gouty flare, second episode will be there within 2 years, okay. For that it is normal, but within 1 year if there is 2 or more episodes are seen, then we can go for this urate lowering therapy and all. Then most important thing is the lifestyle management or the lifestyle changes to be done under the management of gout. So the first and foremost thing in the lifestyle management is good hydration, that is increased amount of the water to be taken, okay, so that to maintain the uric acid level excretion and to maintain the normal thing. Secondly, to avoid this particular food which is high content in the purine. Remember, purine rich food, not the protein rich food. Many patients get confused with the protein rich food. They tend to avoid the protein rich food but here the main problem is purine metabolism, not the protein metabolism. So purines we have already discussed in the pathogenesis, okay. So the purine rich food is like red meat, seafood, alcohol and high fructose corn syrup or the sweetened syrup, okay. So earlier this disease was known as King's disease because usually this high alcohol red meat used to exacerbate these gouty flares or attacks, okay. So generally this will lead to attacks in the first metatarsophalangeal joint. This was also known as podagra, okay. Inflammation of this, it is known as podagra, the name given to this inflammation in the gout, okay. Anyway, so this is the management of this. So lifestyle changes, you have to avoid this food. Then what to eat? So mainly the vegetarian diet, the fruits rich in the cherries and the citrus fruits, you can eat all the herbs, almost all vegetables, but few vegetables like spinach and cauliflower, they will contain the high purine diet, but still even with the high purine diet they will not, generally they are not causing the acute gouty flare. So generally vegetable diet, and most importantly low fat dairy products. In some research there is inverse relationship between the low fat dairy products and the incidence of the hyperuricemia, that is uric acid level is decreased with this dairy products, okay. Then also eggs, whole grains and this nuts and seed, walnuts and all will be useful diet for controlling the gout. Hope our video is very much useful for you people. Just to summarize what we have discussed today, we have discussed about the clinical condition gout, in which we have discussed the definition of the gout, that is it is a hyperuricemic condition characterized by typical manifestation of monoarticular arthropathy and deposition of the monosodium urate crystals. So generally it is males are more affected than the females, and worldwide it is a common clinical disorder. With increasing age, the clinical manifestation is there is acute pain and tenderness in the first metatarsophalangeal joint, which is also known as podagra. Then other joints may also get affected, and sometimes excess of monosodium urate crystals in the subcutaneous tissue will causes the tophi, formation of the tophi in the ear or in the fingers or in the joint, synovial joint itself. Sometimes renal stones can occur, and the diagnosis is by the monosodium urate crystals in the synovial fluid. Under the polarized light, it is negatively birefringent. And treatment, mainly medical line of treatment by NSAIDs and colchicine, anti-inflammatory drugs and glucocorticoids. Generally it will be dissolved, and lifestyle changes is the most important treatment. Then finally urate lowering therapy to be given in selected patients where the drugs like allopurinol, febuxostat, probenecid can be used, okay. That's all for the today's lecture. Hope you enjoyed our video. So please like and share our lecture. videos to your friends. Thank you.